Last year I spoke on autism, and this year I really wanted to address epilepsy, which has really been the majority of my career, and an incredibly important topic for me personally, not just professionally. And I'd like to dedicate really the talk to, see, I'll get emotional, but a patient of mine, Cindy Mae Meehan, who we lost in March last year, to epilepsy. I apologize if I broke up on that, but she was a beautiful girl who I took care of since infancy. I had the great pleasure of knowing. She passed at age 13 due to her seizures. And it really, it highlights the importance of really improving what we do for patients with epilepsy. She taught me a great deal, personally and professionally, as did her mother, Susan Meehan. And I'm sure some of you probably know her. It's worth noting Dustin Sulak, who's speaking tomorrow, also took care of Cindy Mae. And you know, was just very warm and very involved with the family. So that's why we do what we do, is to really to help patients and to avoid such a devastating consequence. So when a new therapy comes up, and this is something that we've had to approach in both autism and epilepsy, is we've had a lot of new therapies, and it's not always clear up front what do we do, what's the best approach, and what's safest for the patient. So it's, in terms of my approach to this, and this really began to arise more in autism than epilepsy when I first started out, but first we have to learn as much as we can about the treatment, and we have to learn as much as we can about the patient, because from those two, we're ultimately going to balance risk-benefit. And that's really what we need to do so we can provide proper informed consent to the family. So some practical things that have helped me in doing this when we have therapies that are considered unproven. One is to make one change at a time, because we have to assess both for efficacy as well as side effect. You always want to start low and go slow when you introduce a new therapy. It's important to define what your goals are up front, so we know at what point do we take away this therapy, at what point you know, should we start to take away some of the old therapies that you've been on. And so what's going to be considered success? And that's sometimes hard to define. And that also requires very careful assessment of treatment response and close follow-up. And we need to know, too, that the therapy itself is consistent over its time course, because we don't want to assume something is ineffective simply because the consistency is an issue. So in my practice, when cannabis was approved for medicinal use, I was in Rhode Island at the time, and in terms of knowing the patient, I first started with the most medically refractory patients, because I figured if we had limited resources at that time, that's who we needed to really focus on first. To make sure that we're doing it the right way, we had, now in a small state, this was actually fairly easy. We only had 2 licensed dispensaries at the time, so I met with them. We tried to figure out what are we going to use for epilepsy. Actually, when they first opened, epilepsy wasn't high on the radar. So we made sure that we got the strains we needed, and we figured out what we're going to use in each patient and how we're going to make sure it's consistent. And as we introduced CBD, in this case we started with AC/DC strains. It was about, at that time, about a 20-1 CBD to THC ratio. We kind of held their other anti-seizure medications stable, so we did one change at a time. We asked patients to keep very close seizure journals, so we did seizure counts for 4 weeks leading up to the therapy with all meds stable, and continued those very close seizure counts after starting therapy. And I did 24-hour EEGs before and after each patient, and also assessed their anti-seizure medication levels. And so that's what I chose to do in my own practice, but at that time I had less data to tell me it was effective, and I wanted to really be sure that I wasn't leading patients down a pathway of something ineffective. I had seen many ineffective therapies along the way for various things, and we wanted to be sure this was really working. And those were the things that we did to help ensure that. I'm going to roll through, I have about like a 2-hour talk here, so I'm just going to roll through it very quickly. But I want to give you some of my challenges in the office. And so having it approved by the state is not even half the battle. And the basic summary of all of this is going to be that the scheduling is a major, major problem in the clinical realm. In my opinion, it endangers both patients and caregivers in different ways. And so scheduling remains a problem, even though we have state approval. And I'm going to give you examples as to why. And so this is a typical patient I'd see. Somebody who has Dravet syndrome is a patient with multiple seizure types, very refractory to our existing therapies, and at risk. These are patients who are at risk of dying from epilepsy. And so having gone through this many therapies, none of which were working or causing side effects, you know, the mother asked me that question I've heard about this. Is this something you can prescribe? And I have to explain that, well, I can't really prescribe it exactly. I can advise consideration, or I can have a First Amendment right to a discussion on the topic. But at this stage, I still can't prescribe it. I have a DA license, which would prohibit me from doing so. And in Massachusetts, we have our own specific requirements. Each state has their own. Massachusetts, for pediatrics patients, you need 2 certified physicians. You have to you have to attest that the patient has one of the medically required conditions. And it's important to note that because I can't technically prescribe it, it really affects the way we practice. So first of all, how do I document that? If a patient's telling me, if I'm helping advise a patient on to how to start their dose, where to begin it, I can't really document that without that fear that I'm actually crossing that line from First Amendment free speech into prescription. Of course, that'll discourage physicians from being involved in this area in the first place because the rules aren't so clear. It's going to limit our ability to provide written instructions, which we should do, but of course this makes it complicated. And so how do we chart? How do we document these things? In our notes, in our phone calls? In this patient, she did start an AC/DC strain, about a 20-to-1 ratio, starting about 1/4 milligram per pound per day, gradually increasing. Did very well, improved alertness, improved attention, no side effects. Seizures pretty dramatically improved. So she has some breakthroughs during her menstrual cycle, which is not uncommon, but only 1 pediatric ICU admission for her in the last 3 years is phenomenal, and again, potentially life-saving. She was somebody who was very frequently intubated and often in the ICU. She continues to keep journals. We continue to review her progress with teachers, with parents. Neuropsychological assessments are very helpful. I think it'd be great, ideally, to do on every patient. It'd be wonderful to see how the kids are progressing with therapy. And we monitor, of course, the consistency of the treatment. We can independently test to make sure that what she's taking remains consistent. And we monitor her anti-seizure medication levels. So other conditions, and I'll roll through these really quickly. I won't present the whole history for each for the sake of time. Again, though, in Dravet syndrome, it's very common that seizures remain refractory, sometimes very prolonged. So in a patient who has seizures that are 20 minutes, 40 minutes, an hour, those become life-threatening. And those present a risk of harm, even if not life-threatening, even a risk of harm to the brain, a permanent risk. And so how can we treat that? Well, this patient was actually giving, and I have to credit Dr. Sulak for starting a few of these patients and helping instruct on this. But this patient was using THC. She was using about 1/2 milligram per pound in the buccal mucosa for prolonged seizures. And worked tremendously well for her. She noticed that before she was using rectal Valium, which caused her to be sedated for the entire day and wasn't working that well in the first place. Using THC through the buccal mucosa, meaning the cheek, seizures were breaking more quickly. The patient was back to herself in about an hour or so. Huge difference. And now that's a little, that always raises some caution for a clinician because prolonged seizures are such a potentially dangerous issue. So how do I do that in a way that's safe? Typically, we would treat with benzodiazepine after about 5 minutes into a seizure. So initially, when the first few patients came with this approach or this question to me, what we opted to do is actually treat them a little bit sooner, just because around a 2 to 3 minute mark, because I wanted to still allow time to see if the seizure broke, and then we still had the option of using benzodiazepine if need be. And that's what most of my patients will do. They now have 2 tools in the toolbox. They can use the buccal THC, or they can go back to Diastat or nasal midazolam, more standard therapies that they've used for many years. Inpatient, this is a daily issue I face. This came up last night. I got paged, emailed multiple people about a patient who's inpatient now. This is a very confusing topic. This will happen, though. If you treat patients as an outpatient, especially for something like seizures, eventually they're going to get admitted. And we don't have hospital systems in place presently to address this topic. So another example of a patient, she had tried everything, nothing worked. Only thing that worked was she was actually on THC daily for her seizure. She had tried really a high CBD product initially, which was not effective. She also used THC as a rescue. So she was using it both as daily maintenance plus rescue, working very well for her, but the problem is every time she had a fever or infection, she'd present with a prolonged seizure and sometimes needed admission. So here you have a patient. The only thing that's worked is a cannabis product. Can you give it in the hospital? And if you can't, can you stop it? Is it safe to do that? So it's complicated. And the short answer is that most hospitals have not worked out a system here where they could do this legally. And the problem remains the federal government plays a major role for hospitals. So the Centers for Medicare and Medicaid, their requirement is that if you have your own medication, whatever it happens to be, whether it's your home medication or an herbal product, they demand that the patient give it to the pharmacist who will then confirm what it is and then dispense it. The problem is that if the pharmacist dispenses a Schedule I medication, that's a violation of the Controlled Substance Act. So you're stuck. And these federal requirements are obviously at odds with each other, but keep in mind, hospitals receive huge federal funding, not just from Medicare and Medicaid, but research funding goes on and on. So they don't want to violate the Controlled Substance Act for those reasons. Some states have taken steps to correct this. In Connecticut, Governor Daniel Malloy did sign legislation to protect nurses. Connecticut and Maine are also explicitly provide immunity to the hospitals. But hospitals are more important in fund. I mean, what's more important to them is actually the funding sometimes than the immunity. And it still doesn't fully address the funding question. And that's why I say that we still have to work out the scheduling. This remains a major issue for the inpatient. And the Controlled Substance Act does state that when you have state and federal law at odds with each other, you have to take the more stringent of those two. Creates a problem. And I'm not a lawyer. I don't want to be one, or a politician. But we have a lot of work to do here. So, because these are the options we face. You could either stop the cannabis products, in which case the patient may go into a prolonged seizure, potentially life-threatening. You could have the patient self-administer, but then Centers for Medicare and Medicaid tell us we shouldn't do that. We should actually confirm what's being given first and then dispense it. Or you could have the hospital pharmacist do that and dispense it, but then they're violating Controlled Substance Act. Or you could do a don't ask, don't tell policy, in which case he does create a little bit of a problem because you're not documenting then what's actually being given. May be an issue if there are side effects. These are the ones I'll go a little faster, but second opinions come up a lot, and I see quite a few patients' second opinions. This gets back to why we have to know the patient very well, and also, that's one critical thing. The other thing is that the physician does need to remain very involved in the care of all these patients, and this patient highlights that. So this is a 10-year-old boy, had been diagnosed in another center with seizures, came to me on 6 different anti-seizure meds. The mom on her own had started CBD, but the seizures were actually escalating upon doing so. And she was wondering, is the CBD making the seizures worse? So to figure that out, what we did is we admitted him for a video EEG. It turned out the seizures that he was on 6 medications for and that the mom had started CBD for actually were not seizures. They were what we call psychogenic non-epileptic seizures. As many as 40, depending on the studies you look at, as high as 40% of patients with epilepsy will have psychogenic non-epileptic seizures. But of course the meds weren't working. This is not what they work for. He did have epilepsy though, so many patients have both. They're not exclusive entities. But it explained why the treatment wasn't working. And this highlights the importance of the physician remaining deeply involved with the care of the patient. And also why we have to have open discussions about treatment. School remains a major issue. So many of my patients have to, this is an example of a patient who was taking a strain called auto number 2, was having afternoon seizures. So it was wearing off. Now, if I used a higher morning dose, she was a little more sedated. We're trying to find that balance. So 3 times a day was perfect for her. The problem is the school nurse can't administer. You know, the schools, again, they receive Title I funding. Most schools have zero tolerance policies for any drugs on campus. And of course, the nurse fears their own liability in administering this sort of product. So what do? I have parents who drive to the school, have to take the kid off the school grounds. You know, I mean, my day's busy enough. My wife and I both work. I couldn't imagine how you do this, but it's not easy. But this is what it has to be done sometimes. Alternatively, you could just raise the morning dose, but then you might risk sedation. You know, so you have to be careful. We do have a few schools that have, a few states that have moved towards protecting kids in school and protecting the schools themselves. And they will allow the legal guardian to administer the treatment, and the students won't be punished for having them or receiving them. So there is some movement towards improving this. Travel, of course, remains an issue. Patient of mine, this came up last week. So all these things I'm mentioning, like every one of these within the week I've managed. This patient came up just last week, got a Make-A-Wish trip to a state where cannabis is not legal, medical cannabis is not legal. So the question is, she called the TSA. The TSA said, you're fine leaving. We're not going to do anything in Massachusetts, but the problem is when you get to where you're arriving, we can't guarantee what the TSA will do. So it leaves the mom with a couple questions. Do you bring it in the luggage and risk dealing with the TSA in the state you're going to? Do you FedEx it to your arrival destination? That raises other issues. Do you hold it for the duration of the vacation and risk seizures? Do you cancel your Make-A-Wish trip that we're looking forward to? You know, all these bad options, right? I could tell you, I mean, I have little side discussions with patients about what I think they can do, but many of those are off the record. So I won't mention those. So that's why I talk about politics directly affects what I do day in and day out. This is a big issue. It affects how we document, how we counsel, what we do in the hospital setting, what I do in school, what we do for travel. The scheduling right now from my patients, and I see a subset. I see mostly kids with autism and epilepsy, but it puts my patients at harm, the current scheduling. It also puts physicians, nurses, pharmacists in the hospitals at fear of legal jeopardy. I didn't even mention research, right? That's a whole other topic. Of course, it limits the physician's willingness to see and treat patients, and this is a major reason why so few physicians are involved in this. It hinders our inpatient care, prevents documentation. You know, primum non nocere is like the overriding principle, first do no harm, that many physicians operate under. But we have to be careful that we don't harm patients for fear of all the legal issues, too. It's a balance. We don't want to administer treatments that don't work or are harmful, but we also want to make sure that we're not harming patients because we're overly cautious about our own liability. And so the uplifting part of this, this is Susan. You see, I'm going to cry. I apologize. But this is Susan Meehan with Governor Malloy, and she worked so hard to get legalization in Connecticut and was successful. And that happened in October, and they named the law after my patient, Cindy May.